Hello, my name is Yejun Hong. I'm a medical student in the University of Calgary and our team is here today to explain ocular migraine. Ophthalmology and neurology are quite closely linked. The eye is a sensory organ that is connected to the nervous system, and it is also physically located very closely to the brain. So, for example, if a brain is under a lot of pressure, so an elevated intracranial pressure, the eye would be directly affected as well. The eye is also innervated by 4 of 12 cranial nerves that sprout from the brain. Cranial nerve 2 is in charge of perceiving light, and 3, 4, and 6 are in charge of extraocular movements. The retina also has a neurosensory layer that becomes the optic nerve when it exits the eye. As one example of the link between these two specialties, we have ocular migraine today. This is a headache with ophthalmologic symptoms, as you will see soon enough. Migraine is a neurologic syndrome with at least 2 from this major pain criteria, which is throbbing, unilateral, and moderate to severe in intensity, and the pain gets worse with activity. And it also needs at least 1 from the minor associated symptoms, one of them being photophobia and phonophobia, and the other being nausea and or vomiting. The duration is 4 to 72 hours, and at least 5 attacks of migraines needed for the diagnosis, and there should be no secondary cause. Migraine can further be subdivided into whether it accompanies aura. Aura is a sensory phenomenon, most commonly visual, as shown in the picture here, but it can also be in the form of blind spots, like the spreading scotoma, can look like tunnel vision, blurred vision, and altitudinal field loss, so either superior or the inferior field. There are also several periodic syndromes in childhood that can occur recurrently with migraine features. For example, cyclical vomiting would be diagnosed if a child vomits 5 or more times within 5 days and also fits the criteria for migraine. Abdominal migraine is when a child has midline abdominal pain for up to 3 days, and benign paroxysmal vertigo of childhood refers to this recurrent, repeated vertigo attacks accompanied with nystagmus or emesis as well. Retinal migraine refers to what we call the ocular migraine. This can last up to an hour because of a diminished blood flow to the retina or the optic nerve. So how does migraine come about? This is a combination of peripheral and central sensitization in headaches. So the peripheral sensitization is from the nociceptors of the meninges and dura vessels. This leads to inappropriate pain stimulation from a normally benign stimulus, such as normal pulsation of the vasculature. The central sensitization involves the second-order nociceptive neurons. This leads to pain and tenderness with the benign touching of the scalp or the face, and sometimes it goes to distal sites of the body as well. Neurogenic peptides like serotonin and dopamine can stimulate inflammatory cascades and eventually lead to the release of those said substances from endothelial cells, mast cells, and platelets. They are especially susceptible for certain individuals because of their baseline state of hyperexcitability. The aura is caused by a cortical spreading depression, which is caused by sudden decrease in blood flow due to repolarization phase of the localized neurons. The headache caused by neurochemical release leads to the inflammation and vasodilation. The risk factor of migraine for an individual includes a family history of migraines and history of motion sickness, as well as epilepsy and familial dyslipoproteinemia. Tourette syndrome, as well as various cranial nerve palsies, can render an individual vulnerable to developing migraine as well, and depression as well as congenital patent foraminovalia can lead to this condition. People with migraine may experience a possible visual aura, and they can also undergo headaches, neurologic symptoms, and GI and emotional alterations as well. For ocular migraines, they may also experience monocular scotoma, and the visual loss lasts from 1 minute to an hour due to the diminished blood flow. There aren't a lot of signs that you may be able to notice in a patient with migraine, but upon a visual field test, there may be some defects. Complications of migraine can include chronic migraines, status migrainosus, which is headaches for more than 3 days and refractory to treatment. Persistent aura without infarction would be diagnosed if it lasts for more than 3 days. And migrainous infarction would be if there's a stroke that accompanies the migraine, and therefore the blood supply does not reach the brain tissues. Migralepsy is a seizure triggered by the migraine. So a lot of brain-related complications can arise from this headache-centered disease. Differential diagnosis for someone with migrainous headaches include the meningitis, tension or cluster headaches, and it may also be a sinus or dental pathology or ENT presentations. It could also be subarachnoid hemorrhage, especially if the patient has thunderclap headaches or very sudden 0 to 100 pain headaches. And for people over age of 50, we may suspect temporal arteritis as well. So for this type of patients, do a complete ophthalmic history, elucidate the precipitating factors for migraines, frequency and duration of the episodes, associated symptoms, and characteristics of pain, if it's throbbing or pressure or spreading in a way. To conduct a neurologic exam, focus on the cranial nerves. Do a slit lamp exam. Make sure there are no other causes that can cause transient scotomas. Check for extraocular movements, pupils, tonometry, and visual fields especially is important to conduct. If measuring vitals, go for blood pressure and temperature especially. If worried about meningitis, consider a lumbar puncture. And for neurologic deficits, check by imaging. Treatment of migraine include resting in a dark and quiet room. The patient may take NSAIDs for pain relief and triptans as well. Because sometimes the migraine symptoms can lead to vomiting, consider antiemetic medications. Preventing episodes of migraines would be avoiding triggers and precipitating agents like foods, stress, and alcohol. Reduce the stress in general, regulate the sleep cycle as well as the meal schedules, and exercise regularly. Beta blockers, TCAs or tricyclic antidepressants, and calcium channel blockers may also play a role in preventing migraine. Treatment should be monitored by an internist or neurologist. So hopefully today we were able to convince you that ocular migraine does play a role in relating and linking ophthalmology and neurology. So this is a summary of everything we talked about. And here is the reference from which we pulled the information to put together this presentation. Thank you for watching this video.